Okay, so this recording is going to be about mobility and fractures, and I'm doing this one because this is the one that I'm the worst at. Other parts that are they're going to be on the test is like Addison's disease, Cushing's disease, diabetes, the extreme part of diabetes, and that I know really well. And there's Parkinson's, but I can pick up Parkinson's pretty quickly. This is the one where this was the first week after the first test. Like this, I don't remember this. This was the hardest for me. So this is what I'm going to be doing essentially. And there's going to be me talking a lot and me also not knowing anything that I'm talking about. So there's going to be multiple instances where I just don't know what's going on. Anyways, mobility. Mobility is like a spectrum. So I think I mentioned like a couple weeks ago, you shouldn't take your mobility for granted because, you can go from being completely mobile to completely immobile over like a freak accident. So it's like there's just a range of people. Um, some people have full mobility, some people have like impaired mobility, and some people can't like move at all. And we talk about mobility because that can really affect your lungs, your respiratory, and that can affect like incontinence. So I think we'll get into that later, but essentially, kind of like a rundown. If you're immobile, you're essentially laying in bed. If you're laying in bed because you can't get up, that means you can't go to the restroom, which means you're essentially wetting yourself, and that wetness is impairing your skin integrity down there, which makes you more likely to get pressure injuries, stuff like that. But also, if you're laying down for too long, you have risk for like DVT, deep vein thrombosis. So essentially, like a blood clot in your vessel or like your vein. It can travel up, give you a stroke or like an embolism, but they don't want that. So you kind of have to think when people come out from surgery, they give them blood thinners because they're going to be laying down a lot. And really, any patient um, that they know is going to be laying in bed for most of the time called like it's called prophylaxis. It's preventative measures. They give them blood thinners so that they won't get a clot, they won't stroke out, something like that. But immobility can also affect your lungs because when you're laying down, you're not really like taking big deep breaths. So you have little alveoli. You have little alveoli. So I have no ability to draw, but essentially you have. Oh, but I have a little screen. Let me see. You have like this. It's your branch. This is like your trachea. You have your two little branch, and then you have your alveoli down here. Those alveoli, that's where gas exchange. It's like a little ball. Gas exchange happens through here at the end of each of your little bronchioles in your lungs. And if you're not actively like using those alveoli, they'll essentially collapse and you'll have respiratory distress. So we'll see a little bit later on in these slides that immobility can affect your respirations a lot. So, anyways, so this is just basic stuff, um, mobility. It's the state of being mobile or movable. But And then we talk about risk factors for becoming like immobile. So like this person's obviously in a car accident. So like your age um, can affect your mobility mostly because if you're old, you're more likely to fall because like you're weaker, like da da da, that stuff like that. Conditions like trauma and surgery, because I just talked about that. If you're in pain, like you're going to be at a higher risk of falling. Um, Key factors they want to mention, this is musculoskeletal. That's what MSK means. So, musculoskeletal is kind of talking about like your spine and like your back. So, without having like a good musculoskeletal development, or like a, how do I phrase it? Like if it's not well built or if it's damaged, then you're not going to be able to move real well, because neuro has it, like your spinal cord, well, your spine, that's the biggest part of like your mobility, that kind of controls everything. Because I was telling you a few weeks ago about your spinal cord, that's where like the nerves kind of branch off from there. So it really, listen, I don't want to explain, I just know, okay? I hope you know. Anyways, causes of immobility, you can have impaired nutrition, pain, I just mentioned, the gas exchange that I mentioned a few minutes ago. These arrows are back and forth because, like, pain can cause immobility, and then the immobility can cause pain. So, like, you kind of think of it as immobility can cause impaired, like, gas exchange. And if there's impaired gas exchange, then the body isn't going to be perfusing oxygen correctly. It's the same type of thing. Um, Nutrition, I think it kind of lists this here because when you're in the hospital, a lot of people are on like very specific diets. Um, so if you're laying in bed for too long, your muscles can atrophy, or you can have like, or AKA muscle wasting. So then you might need to like alter your nutrition and like your diet plan so that you get more protein so that doesn't happen. But like I was saying, this affects this down here. So like that tissue integrity is affected. Tissue integrity is affected by the incontinence. So like the feces and the urine, like it saturates the skin, and then it makes the skin easier to like shred. And the same thing with elimination. Like if you can't get up, you can't go to the bathroom. I don't know what they're talking about. I'm already at 7 minutes. Don't be scared of the 85 slides. I mean, be a little scared. I would be scared for sure. Um Anyways, range of motion is basically like how far you can take things back and forth. Um, this is backwards. Abduction is out. Adduction is inwards. So basically, like your range of motion is like um, how you can move things. Um, Passive range of motion would be like if someone was moving something for you, if you couldn't move, but it's range of motion is all about maintaining the muscles that you have so that your muscles don't atrophy. So like if you had some sort of like leg surgery, there if you can't ambulate on it, then someone might come and like move it for you so that you can keep the muscles in there, because you wouldn't want to get injured and then you're trying to heal whatever was injured, but the muscles are wasting because you can't like use that limb or that muscle. But anyways, this is kind of like a an assessment, whether someone has full range of motion against gravity and like resistance, and like whether they don't. Um, what the hell? Um, so when you do any assessment, you kind of also have to take into consideration all the other factors that are um, like with it. So like past medical history influences whether, gosh, do I really have to explain? I feel like you'd already know. Past medical history, family history, like that all influences whether like someone is more prone to like get something, if maybe it's like genetic. Then lifestyle behaviors can be very indicative, like or someone's occupation, what they're doing, how they're doing it can lead to health issues like later on, and especially like their environment, like if you're working in a really polluted area, then that's going to affect your health after a while. um Symptoms, obviously, because we're talking about fractures, this would be pain, obviously. And then you're going to have reduced joint movement because, it's broken. Um, Loss of sensation because, it's broken. Falls. Falls is because whatever's broken is broken. You can't, if it's like your leg and you can't put weight on it and you try to put weight on it, you're going to fall. Same thing with fatigue. Like, your metabolism is high, like your body is using up a bunch of energy to try and heal whatever's broken or whatever's wrong, so you're going to be tired. Altered gait or imbalance, like if your leg is broken, then you're not going to be able to walk right, or like you're not, you're not going to be balanced correctly. So reduced functional ability, that's literally what everything else is about. um okay, this is a good slide about complications. um oh, I should go do this actually. Let me take a picture real quick. um Prevention, so like they teach us a lot about preventing falls and stuff like that. So your primary is like, this is 100% prevention. So primary is like adults who are primary is like education, and you want to take people who are at risk of falls, so like older people past like the age of maybe like 45. When they come in for their checkups, maybe they don't have any health conditions or incontinence, or they're pretty much fine on their own, but because of their aging and risk factors, you want to educate them about how to prevent a fall, or don't have any loose rugs or cords or good lighting in the house. You start teaching them that type of stuff so that it can prevent something later on when maybe they have a condition like osteoporosis or any other conditions that might affect their mobility later on. So, secondary is, so if primary was just a group of people you're trying to educate to prevent, secondary is now you have people who are like specifically at risk for falls. So this would be like your screenings. So what would be an example of like a secondary prevention? So maybe somebody with osteoporosis, someone who just got surgery, you're going to go teach them. You're going to say, hey, okay, here's the things you're going to want to do, and here's the things you're not going to want to do. They haven't previously fallen, but they're more at risk for falling. So, like, I don't know. Like, I just know the difference. This is a shitty explanation. Anyways, tertiary is when somebody already has, like, maybe somebody already fell already, and now you're going to talk to them and say, okay, here's what we're going to identify as being like the issue, and here's how to prevent it again. So primary is like education to like anybody mostly. Secondary is like, now we're screening people who are at higher risk for falling. And then tertiary is, okay, now this person has fallen for whatever reason. Now we're going to analyze what happened and try and prevent it again. So this is like your just general guidelines on how to prevent because like I was saying, when you lay down for too long, not your muscles are wasting, like you're not taking full deep breaths, so you can go into respiratory distress. Like, did I say your muscles are, yeah, your muscles are wasting, respiratory distress, like you can become incontinent. So these are a few things to like try and prevent the complications of that type of stuff happening. So the turning and positioning and alignment, that's to prevent your pressure injuries. You want to rotate them every 2 hours. um, your skin assessment, skincare, that's you want, whenever you turn someone, you kind of want to look to see if they have a possible pressure injury. You always want to be assessing their skin, um, because what are they called, like audits or something? They go and look at the hospital, and the hospital can get bad ratings if the patient doesn't come in with the pressure injury and then they leave with the pressure injury. So you don't want that to happen. It's the same thing with like falls. Falls are huge for the hospital because if the patient falls, that goes against the hospital and it looks bad against the hospital. Like that goes on record, and yeah, like they can see that. Anyways, range of motion, you want to like move the patient, deep breathing, really use those alveoli. Weight bearing, if possible. This is to help to prevent the muscle wasting. Same with the range of motion. Measures to optimize elimination. So if like someone's incontinent, you really want to like clean them up after they have a bowel movement. Clean them up after they uh, urinated in the briefs or the chucks. Do your best to keep them clean and dry always, because that really helps with that skin integrity. Nutrition is kind of what I talked earlier. They might need like a different diet that caters to their needs. And then obviously, you always want to educate the patient on why they should get up and moving, because many patients get surgery, they come back to the unit, they're tired. Oh, I don't want to go to physical therapy, I don't want to go to PT, I'm tired, I'm in pain. And you have to tell them, hey, I know you're tired, but you can't lay in bed because essentially you can get a blood clot, which is why they're giving the blood thinners. But then the risk of giving blood thinners is that if they get injured, they can bleed out, because then your blood can't clot and stop that like injury. They can't plug the injury. So you just want to tell them, your muscles can waste away essentially, but in a polite way. We're gonna skip these because these asshole professors never told us the answers, but they're good to work through. Fractures, pathophysiology. So different types of fractures, like down here. We'll get to the pictures in a little second. I think traumatic versus pathologic, whatever the what? Oh my god, I'm at 17 minutes. This is gonna be so long. You're never gonna watch this, which is why I should leave secrets in here because you're never gonna watch it. Um, Key terms: traumatic versus pathologic. Traumatic fracture basically means, boom, car accident, you broke something. That was like it's like a primary incident. Pathologic, I'm pretty sure it means like you have a condition, and then there's a secondary reason for a fracture happening. So if a woman has osteoporosis and you don't have enough calcium, and you've got osteoclasts essentially breaking down your bone, making your bones more frail, and I don't know, maybe this old person has a fall and then their hip breaks, I think that would be pathologic because it's a secondary condition, something like that. Complete or incomplete? Complete is just, complete. Incomplete is incomplete. Displaced or non-displaced? I don't really know what this means. I think displaced might mean maybe the bone isn't fractured, maybe it just came out of like its socket or something. Not really sure. It's just different ways to describe the fracture. And then linear is like linear, or like linear. Transverse is sideways. Longitudinal, spiral. Okay, we'll just get down here. Open, this one's easy because this one's piercing the skin. You can see it. Closed, this is how I would assume most fractures or breaks happen. You can't really see it unless it's on x-ray. Transverse, um, transverse is always like horizontal. Spiral, it's like diagonal or in a spiral. Green stick, I think this is one of those incomplete because it's not all the way across. Comminuted, I don't know if you can like look. You've got a bunch of little like crumbs in there. I think that's what's specific about this one. Um, Not sure how they would fix that, but that's different. Um, oh, this is interesting. I want to know what's the difference between an oblique and a spiral. This must not be all the way through. I'm gonna have to ask. Stress fractures are just when you put too much pressure on something and you can get like a little hairline fracture in there, although I don't think you can really tell from this picture. Um, Stages of healing. So you fracture whatever you fracture. There's a bruise, there's, bleeding, there's going to be swelling, um, that kind of stuff. Granulation tissue, this is new tissue that's going to be forming and healing. Um, I don't know what callus formation. This must be like pre-ossification. So I think essentially what they want to do is you break it, it swells, you want to put ice on it. You want to let the swelling like happen to its fullest extent before you put the cast on, because you don't want to put the cast on too prematurely, because if you do that, then you're going to put the cast on and then it's going to swell more. And there's that thing called compartment syndrome. And do I have that on here? We should get to that later. Compartment syndrome is something we talked about a real long time ago, where when the swelling of a fracture or break is so much it cuts off blood circulation. So essentially, you have a fracture, it swells. You put on the cast before it fully swells, and now your body keeps swelling and swelling and swelling and swelling so much that it cuts off blood circulation. So if I fractured something here and they put a cast on it, then it keeps swelling. All of a sudden, if this blood circulation is cut off here down, this is going to start like necrotizing. It's going to start dying because there's not enough perfusion and there's not enough oxygen getting to this extremity. So essentially, you don't want to do that. And then for compartment syndrome, you just want to remember the 6 P's. So pain, paresthesia, pressure, paralysis, pulselessness, pallor. So pain is an easy one because you're going to have pain. Pallor means it's like pale. If it's pale or like blue, that means, cyanotic hypoxia, not getting enough oxygen to that extremity. Pressure, you're going to feel pressure because the cast and the swelling, it's really intense. Um, Pulselessness, if there's not enough perfusion, then you're not going to get a pulse, essentially, because it's not happening, like the blood ain't going there. Um, Paralysis, I'm not really sure. I think you could lose like mobility if it's really dying that much. I don't know. Paresthesia, I think that's some form of like uh, nerve sensation. Anyways, let's just move on. So when you assess someone with fractures, maybe some of the expected findings you would find: bruising. What the hell does crepidation mean? Deformity. Okay, bruising and edema. This is the swelling. So this is pretty easy stuff. Loss of function, easy. Muscle rigidity or spasm. I could not tell you why. They just said that muscle spasms, they happen. And that's why the only medicine I can ever remember, uh, baclaflin, that's supposed to help with muscle rigidity. But it's also, they have this thing called like buck tract. Um, what is it called? Buck skin traction. It's where they put little poles in like your bone, and they like pull it and they like adjust it and they get it all right and set, so that reduces like muscle rigidity and spasm. Like, I don't know, like I don't know if you could see stuff kind of like that. What the hell? Everything's frickin' backwards. Yeah, anyways, we'll come to a slide. Loss of function, that one's easy. Deformity, yeah, I mean, I feel like these are pretty easy. Diagnostics, X-ray, MRI, CT scan, easy peasy. So this is what we were talking about. This is kind of like the steps you would want to take um, when someone comes in with a fracture. So essentially, let me pull up my notes real quick. Um, you want to reduce it. Basically means like, what does it mean? What does reduce mean? Reduce, immobilize, and then open fractures. Oh, open fracture debridement. Um, reduce. Hold on, give me 3 seconds. Back when I used to actually take notes and not just sit in class. Although I don't take notes anymore because it's too much. I think. How do I? Crepidation is. I have crepidation written down as Rice Krispies. What the hell does that mean? Um. Okay, see, I wrote down. See, this is a question I asked in class. What the fuck does reduce mean? So reduce, put back into alignment. So you fracture something, you're gonna put it back the way it was. But again, you're gonna let it swell, you know? Um, so these traction things was what I was talking about, the buckskin traction. Um, I'll kind of explain these more when we get to the pictures. So essentially, reduction. So someone comes in with a fracture, you're gonna let it swell, but you're also gonna want to keep the swelling down. But once it swells, then you put the cast on it. You want to make sure you have 2 fingers that fit underneath the cast. Um, Once you put it back into alignment, then you put the cast or the splint on. You put them in traction if they need be, if they're having the muscle rigidity. And then for your fractures, like the open fractures, because it's like breaking the skin, there's bacteria, so you might need to like debride that or irrigate it, stuff like that. And then prophylactic antibiotics is kind of what I was talking about. Prophylactic or prophylaxis is your prevention medications. So you're kind of just giving these antibiotics like in case. You know? I don't know. I don't want to explain. This is too fucking long. Um, I hope these pictures don't scare you. They scare me. Um, this is just a cast. Yeah. So this is what I was showing you earlier. This is types of traction where this is to help um what's it called? Reduce the muscle rigidity or the spasms. So like they put these little poles into the bone and they can pull it so that there's not so much pressure maybe like on the joint like up here. I don't know, that's not really true, but you kind of have to get the gist, you know? So this kind of looks like how they fixed a comminuted fracture where you got all those little tidbits in there. And I think this is just one of the things they were talking about. Just an example of how you would fix one of the fractures. I don't know if it talks about um what the hell am I looking for? I don't know. Traction. Here's what I was talking about. Um where's the buckskin traction? See, I don't know. The buckskin traction is that they put like this tape on your skin and the tape is supposed to really hold real well and that's what pulls the bone. Um Buckskin traction. Pulls bone, applies tension to reduce muscle spasm, and assist in realigning bones. It's to decrease pain and trauma to surrounding tissue. Yeah, that kind of makes sense. So these are again one of our biggest priorities in the hospital is to avoid these complications as much as possible. Hold on, my roommate. Um, Complications, like I said in the hospital, one of the biggest things that we're trying to like not happen is what's it called? Like these complications. So what the fuck does non-union mean? I don't I don't know. Pressure injury or skin breakdown, we definitely do not want that to happen. That happens because, if you don't rotate the patient, basically, if you're sitting on the same, if you're laying in the same place and there's too much pressure on one area, you'll get a pressure injury. That pressure injury happens when you're like, that person is immobile. So, this is what we're talking about. Everything can just like, it affects everything. Um, if you get a fracture and you get a surgery to heal the fracture, and then you're immobile and you're not doing anything and you're not getting up and moving, then you can get a pressure injury, which can then lead to an open wound, which can lead to an infection. So stuff like that. This is also because of when you're immobile, like the incontinence I was talking about. Um, and then atelectasis, that's when your alveoli collapse. If you're not taking big enough deep breaths, so that can be a real issue. Compromised blood flow, like a blood clot, compartment syndrome. That's what I was talking about when your blood circulation gets cut off because they put on the cast like too early. Infection, like I was talking about, you can get open wounds. Constipation, so you can actually get constipation if you're just immobile. If you're just laying in bed, you're not getting up and moving, then your GI tract is not getting up and moving. Then you're going to get constipated. So then, like I said, you get muscle weakness, muscle atrophy, muscle wasting. It's all the same thing. Like inactivity, everything gets stiff, and then your body just starts to eat itself, and then the nerve damage goes with that too. And then it makes a longer recovery time. And then this is just random shit. Mechanical malfunction leading to re-injury. When does that happen? Um, the rhabdomyolysis, that's just um it's like a specific condition that has to do with muscle wasting. Compartment syndrome, this is what I was talking about. This is kind of an early photo. So you can see that the pressure built up so much that like you can kind of see it busting out. So this is like I said, you put something swells so much and you put a cast over it. Um and you constrict the blood flow. So the one thing that they really stress to us about this is the fact that this is one of those things where you see that if you have an assessment and you see that and you're like, oh shit, like I think this is compartment syndrome. It's not one of those things where you can there are many other times where it's like, okay, you know what, the nurse can do a few things before you have to call the provider. Like you're going to let the provider know what you suspect and what you did and what the outcome was. But this is the time where it's like you do not do anything, you immediately call the provider. Like just you do absolutely nothing. It's not our job. So moving on. Oh look, we're like halfway through. Diagnoses. So like these go with the complications I was talking about. So like impaired gas exchange. If you're not breathing correctly, then you're not having the gas exchange isn't happening, which affects the tissue perfusion. So like, and then this is another thing. If you have like a if there's something impairing your breathing, whether it be like physical, like a blockage or anything, that impacts the gas exchange, that impacts the tissue perfusion. So it's like the same thing. So this is what when they say, when I first joined nursing school, I was a little confused because they say nursing diagnoses, but diagnosis doesn't mean it's a diagnosis for like the patient. It doesn't mean that they have this. It means like they're at risk for like developing this essentially. So this just goes with the complications. Planning. So when I was telling you all about the nursing process, you assess them, you analyze those cues, you make a plan, you put the plan into the implementation, put the plan into action, and then you evaluate the outcomes. So the goals for a patient that would have fractions is one, reduction. So put the bone back into place. And two, immobilize it so that no further damage can be done. The healing process can start. Pain relief is always a big one. Prevent further injury. Obviously, I just said that. And then restore function. Therapeutic outcome is a goal for everything, every part of the nursing process, essentially. So, interventions. This was that traction I was talking about. This is like the buckskin traction. Um, the one thing they told us about this is the weights should never be on the floor. The weights should always be like right here and be able to move. This is just different photos of different interventions. This is a splint. These are casts. Um, this is assessing casts. Give me 1 second. So assessing the cast and the traction care. So you want to understand the purpose of why you gave like a cast or the buckskin traction. You always want to assess the tightness. So like I said, 2 fingers underneath that cast. Anything less. So if you put a cast on and you put 2 fingers underneath, and then 2 hours later you come back and you can't fit your fingers under there, and you can't get a pedal pulse in the foot, and maybe the sensation has gone down in that foot, and maybe it looks a little pale. That's You have to put all those things together that says, oh, perfusion problem, oh, swelling, oh, probably compartment syndrome, or at least in this very narrow-minded case where they give you symptoms and it's like, oh, it's that one because that's what we learned in class. It can't be anything else. But out in the field, it could be anything. But so yeah, assess skin integrity. This is just everything you want to assess. Always log roll the patient. Always be assessing. Assess for complications. You're just prevention, 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 prevention. Cast and traction care. So what you want to do to intervene. The first 24 hours you want to apply ice, but you don't want to get the cast wet because then if you got a cast on, you got moisture underneath there. One, bacteria. Two, skin breakdown. So you don't want that. So you want to elevate it, but like ice and elevate the first 24 to 48 hours, but like not after that, I don't think. No scratching. You want to position the patient for the correct body alignment. The last thing you'd want is, you know, get the patient all aligned, all set for the proper healing process, and then find out like it was the bone wasn't aligned and they were turned and all of a sudden it's healed in the wrong place. Like so move joints above and below. So just make sure like practice those range of motion, those passive range of motion, keep those muscles intact and like movable essentially. Um yeah, post-op care, vitals. You always want to get them ambulated real early so that their muscles don't waste away. Proper pain control, proper alignment, assess, like I was just talking about. Pharmacological interventions. Okay, so your anti-inflammatory. This is for maybe like fevers or anti-inflammatory. So I think this is reduced swelling, I'm pretty sure. Analgesics, pain medications, DVT prophylaxis. DVT is your deep vein thrombosis, which I was talking about earlier, which is essentially, your blood can clot and you can have a stroke. So Prophylaxis is prevention. It took me weeks to figure out what prophylaxis meant. And now I'm telling you right now, prophylaxis medications is like the blood thinners that they give so that every patient who's going to be like pretty much bedbound in the hospital on the unit, they're giving prophylaxis medications for DVT, those blood thinners, so that they won't get a blood clot. Nutrition supplementation. This is just everything I was talking about earlier. No need to state what I said twice. Interventions. Turn them, get them up, transfer them, dangle them on the side of the bed, range of motion, patient education, prevent complications, repetitives, the same thing over and over. Collaborative interventions, they talk about some of this stuff so that maybe the other teams you'll have to collaborate and communicate with. So like PTOT, you want to consult them to get them up for like the ambulation, joint mobility, stretching, balance. This is just pretty easy stuff, I feel like. Hip fractures, we get into this because old people are at high risk for falls, and like this is like a big one. So it's often an older patient, osteoporosis, I was talking about earlier, extreme sports. I think mechanism of injury. I wonder what the hell that means. Oh, okay. So she was telling us about this that you can kind of see how like this has a little neck and this doesn't. So like this essentially got squished in. And it's not specifically like a fracture, but there's something definitely wrong for sure. Oh, that one's scary. I don't like looking at that. So essentially, if you have arthritis, you've got that inflammation around where like the hip connects. They're gonna take that off. They're gonna drill in, put this metal shit in there, and they're gonna pop it in, and then it can move around like this. And then it gets into like exercises on, oh, now it talks about buckskin traction. What the fuck? But a little later on, it'll tell you the exercises you can and you shouldn't do for when you have a complete, is this what, arthroplasty? So again, same thing, reduce, immobilize, maybe possible debridement, but that's for fractures, not for, something that's internally. Reduce that traction I told you about, put the bone back into place, immobilize, traction, log roll. So when someone gets like a hip replacement on one side, there are certain exercises they can and can't do. Here, I'll just go down. The surgical approach does matter. So whether the surgeon went in through like the muscles in the front or the muscles in the back determines how the patient can move their leg afterwards. So let's see. I wonder if they have. No. This is. You'll see. You'll see. Um. So anterior. This is the front, but most of them happen. Most of these arthroplasties happen in the back. So, oh, I hope the camera's not in the way. The camera's in the way a little bit. Let me see. Can I zoom out? What the hell? Where'd it go? Oh, okay, a little better. Of course, then now I can't see. So I think posterior is the more common surgery that happens. So like, you don't want to bend down. You, um, no crossing of the legs. You don't want to pigeon toe like your feet or like your knees at all. That doesn't make any sense. Don't put your knees together. It's all about mobility. When you do the exercises that you shouldn't be doing right here, then essentially you're putting stress on that hip when maybe your hip isn't really ready for it, and you can just cause more damage. But yeah, buckskin traction, like I was talking about earlier, it just pulls the bone to reduce the muscle spasm. It's tape that's applied. I'm with weights. I don't think it's like a pole in your bone like some of these other tractions. Um, Yeah, monitor, prevent, check those distal pulses because that could be an indicator of something perfusion is going on. But this is everything I talked about post op. So this is a little pillow, which is kind of important because, again, or not again, it stops the rotation of the hip and which prevents these from happening essentially. So when you log roll a patient, put this pillow on them, and that will really help them not like accidentally move. So just like the fractures, remember when I was talking about the fractures where someone gets surgery and then they have to like get them up to prevent muscle wasting? It's like the same sort of concept. You want to get them out of bed quickly. You want to get them up and ambulating early as possible. Get physical therapy in there. Monitoring their wounds because obviously if it's a surgery then there was like an open wound and like monitoring for infection. That abduction pillow, like just what I was talking about, you don't want to be putting stress on that hip. You do not want to be um, putting those crossing your legs. This is the same thing as what I was talking about. Immobility can have a pretty systemic effect on the body when, well, you're just not moving. So essentially, like I said, pneumonia, if you're not taking those deep breaths. I don't know how the fuck this happens, but I did talk about, skin breakdown, muscle wasting, bone demineralization. It's kind of like the same thing where your bones will start breaking down because for the calcium. It's kind of like the same concept as the muscle wasting. Hip fracture prevention. So this is that like primary, secondary prevention I was talking about. So with an aging adult, it is obviously it's well known that they're going to have, as they age, they're going to get more mobility issues. So you want to educate them about their mobility and like the weight bearing and the just how to prevent it. So eat well, never ever ever smoke ever. Screen for osteoporosis. This is secondary prevention because someone has risk factors for osteoporosis, then they're going to screen them. Diets, vitamin D, and calcium. Just, things to keep in mind. I don't know if you've ever had like an aging grandma or maybe parents at some point or any really aging adult, they'll tell you because aging adults tend to have like the muscle atrophy, their muscles are just getting weaker. Like you can't hold as much weight. So just like little exercises um, really helps out to keep those muscles working so that the muscle wasting won't happen like as badly essentially. So those weight bearing exercises is pretty crucial. Case study. Miss Smith is an 87-year-old who fell at home, complains of hip pain. What would you expect to see during your physical exam that would make you suspect a hip fracture? Pain, um, loss of mobility, maybe depending, like, can't move the leg a certain way. Um, Maybe can't move as well. It's all about immobility. Maybe if they have a previous diagnosis of the osteoporosis. Um, See, this is the same thing as earlier. This has a neck. This doesn't have a neck. That means there's an issue. Miss Smith is coming from the ER to your unit. How will you prepare the room? See, this is the kind of fuck ass questions they give you in nursing school. When the hell did we go over this in the lecture? Like, we didn't. Prepare the room. So, what they kind of want you to think about is if she has a hip fracture, how are you going to need to cater the room to her needs? So, maybe you'll have like the supplies ready for a cast, or maybe you'll have assistive devices like a walker or crutches or a wheelchair in the room. Maybe you'll have like the little buck traction thing set up already. Maybe you'll have the abduction pillow ready. Just stuff to kind of keep in mind when you have a patient incoming. You figure out what they were admitted for, so that not only you can mentally prepare, but if they need anything specially catered to the room, then you'll know. What can we do to help her pain? Pain meds. um, let's see. You'll want to, it's like that treatment I was talking about. Reduce, you're going to put it back into place, immobilize, maybe ice, um, keep the swelling down. Just really immobilize it, realign it, stuff like that. After surgery, yeah, mobility medications. Ooh. Okay, this is something I have to go over later. This is a problem for later. Anyways, this has already been a way too long of a video. And I know you're not going to watch it, which is okay. Maybe I'll re-listen to it another day. But bye!